Hey everybody, in this last module we're going to cover HIV and AIDS, a little bit about adjustments you need to make for elderly and children, and then finish up with a brief overview of vaccines. So to begin HIV, we're going to skip over a good bit of this because a lot of this is going to be managed by someone who specializes in the treatment of HIV. It's not something you want to manage in a primary care office. You just want to be able to look at certain things and ask your patients good questions. Make sure they're on appropriate therapy. Be able to identify those medications, and then know which ones things you need to look out for, such as drug interactions and compliance. So we're going to skip through a good bit of this. Antiretroviral therapy, or ART, are your drugs of choice for HIV treatment. You can see at the bottom, drug resistance is a big challenge with ART, which is why compliance is so crucial with these patients. If they miss short periods of their medication, then the HIV virus they have can become resistant to the medicine they're taking, so it can limit which options we have in the future. So your principles of therapy. Previous guidelines recommended antiretroviral therapy, or ART, based on the CD4 count and whatever HIV viral load cutoff is. But as of 2013, antiretroviral therapy is recommended regardless of what the labs are. So if they are HIV positive, they are to be on antiretroviral therapy, period. There is a lot of improvement in efficacy and tolerability of our new antiretrovirals, which is why we've kind of had a change in the base of what our therapy is. So our therapy is 3 active antiretrovirals from at least 2 classes. For a long time, it was 2. Let's see if we have them. That top bullet, the nucleoside reverse transcriptase inhibitors, it was 2 of those, the NRTIs, and 1 of another class. And you would bounce around in between them and see which one the patient tolerated and which one was effective. Now, the therapy is really based on the integrase inhibitors, which we'll talk about in a little bit, because they're so much more tolerable and they seem to be very effective, and the HIV virus has a harder time becoming resistant to them. So we still use those in our NRTIs, don't get me wrong, but that's not the main focus of our therapy. So resistant testing, the third bullet, is indicated on treatment-naive patients and anyone who has treatment failure. So you're going to get resistance testing the first time a patient gets tested positive for HIV, because they may have a virus that's already resistant to certain medications. Then, when a patient fails therapy, you're going to test them again to see which one of the drugs the 3 you were giving they became resistant to, or did they become resistant to all of them. The primary goal of therapy is an undetectable viral load. Therapy is lifelong, and that's okay because with the drugs we have on the market now, HIV is no longer a death sentence like it used to be. So patients can be on these drugs for decades. The only time it's acceptable to substitute one agent for another is when there's drug toxicity. If a patient cannot tolerate a drug, then you can say leave 2 of the drugs they were on and just sub out that third one. If a patient fails therapy, you have to go back to the drawing board for all of them. There's no way you can't know that. I bet they failed this third option, so I'm just going to substitute it out. No, you have to get testing each time. Here's some information about initiating. Here's the medications, the classes. So you have the NRTIs, the NNRTIs, so non-nucleoside reverse transcriptase inhibitors, protease inhibitors, fusion inhibitors, integrase strand inhibitors. So those integrase inhibitors are getting a lot more focus these days and are really becoming the backbone of our antiretroviral therapy. And then our CCR5 antagonist. These slides here show you the current antiretrovirals on the market. You can see there's a lot of NRTIs and NRTIs. There's quite a few protease inhibitors. And all of these different classes, they inhibit the viral replication of HIV somewhere in the process. So that's how they work. They stop the replication of HIV. You have one fusion inhibitor, 3 integrase inhibitors. I believe there might be another one on the market that I'm not quite sure. 1 CCR5 antagonist, and then a post-attachment inhibitor, which is fairly new. It's a monoclonal antibody. I'm not quite sure where it fits in the algorithm. There are a lot of fixed dose combinations. These are great for patients because it's so much easier with compliance. If you can get away with one of these, if your patient is not resistant, do these. It's so much easier for patients. You'll see going down, there are some that have 2 drugs, and it moves down to 3. There's even some that have 4 drugs. And you might be wondering where that 4th drug come in. Well, the 4th drug in a lot of these makes one of the other 3 more bioavailable. So it is required, but it's not actually active against HIV. When you're looking at these, if your patient is not on one of these tablets, it's easy to use. Always double check with them when they come in, even if you're in primary care, anywhere you are. Ask them, are they still taking it? How often do you take it? A good way to ask it, instead of saying, hey, are you still taking this every day, is to say, in a given week, how many doses would you say you miss on average? Patients are a little more willing to admit it if you give them that kind of question, as opposed to an accusatory yes, no, are you taking it question. So your regimen is determined by all of these factors. So then they would pick the regimen that's best suited for the patient, usually more tolerable medication, and the patient would take it every day, stressing the need for compliance because of resistance. So usually you can see here, even in this slide is somewhat outdated. It's based on the current guidelines, but I think the guidelines are really changing to be where they were at 2 NRTIs plus 1 protease inhibitor. They're really going to 2 NRTIs plus an integrase inhibitor. That's really becoming the backbone, the go-to therapy because of tolerability. Cost considerations: HIV medication is expensive. Almost all of it is name brand only, but medications have great patient assistance programs. There's a lot of money going into HIV and AIDS treatment right now, so that really benefits everybody, not just in treating patients who have HIV, but like we'll talk in a minute, patients who are at an increased risk of exposure. There's great co-pays and patient assistance for those patients also. Medication resistance can be due to poor adherence, drug interactions. There's a lot of them. I'm going to repeat that again. There is a lot of drug interactions with these medications. They go through our major cytochrome P450 enzymes. Any patient you have on HIV, when you start a new medication, you need to run a drug interaction check. They also can have drug-food interactions, or changes in abnormal absorption, distribution, metabolism, or excretion. So you would want to look at a patient who maybe has developed ascites or really bad edema to see maybe to check see if that's going to affect their antiretroviral, or refer them to the managing practice. Failure is defined as the inability to maintain suppression of a viral replication to less than 50 copies per ml, and the causes could be suboptimal adherence or because of toxicity. You want to monitor all these things in your patients. You can see there's a lot, but we want to be very thorough with these patients, because if it's done correctly, these patients can have a long life expectancy. There are some opportunistic infections we have to watch out for with patients with HIV. If you have a patient whose CD4 count drops below 200, your patient is at a much higher risk of getting pneumocystis. Of getting pneumocystis. So you're going to give them Bactrim once a day. Excuse me. One double strength a day, one single strength a day, or one double strength 3 times a week. And you can see the alternatives listed there. If your patient goes under 100, you're going to give them Bactrim once a day also for toxoplasmosis. If your patient goes under 50, CD4 count goes under 50, you've got to prophylactically treat for Mycobacterium avium, or MAC, with azithromycin 1,200 milligrams a week with alternatives listed below. Now, if your patient's CD4 count goes back up, which it can, with adherent treatment, you can take them off that antibiotic at that point. Pre-exposure prophylaxis. This is growing a lot, actually. And you've probably seen commercials for this on TV. So you may consider for any of the following populations deemed as substantial risk of HIV acquisition, maybe risk based on the number of new partners, frequency of condom use, new STDs, sexual practices, or sharing needles. And those could be patients who are sexually active adults with males having sex with males, heterosexually active adults or men or women, adult injection drug users, or adults with HIV positive partners. You can give them scheduled antiretroviral therapy for the prevention of HIV infection. You would also possibly give patients pre-exposure, post-exposure prophylaxis for patients who maybe can't come into contact, maybe due to an occupational exposure. If you've given somebody an injection and then accidentally stick your finger with the needle, there are guidelines from the CDC. I believe it's the CDC that say how long someone should be on antiretroviral therapy if there is a post-exposure or for post-exposure prophylaxis, if the patient is unknown if they are HIV positive or not. And most of your patients, you're not going to know right then, so you would at least start the post-exposure prophylaxis if they agree to get the testing, until that lab result came back. But there are guidelines recommended, I believe, by the CDC. I would look those up and have them handy just in case, because we all deal in a practice where needles are used. Final points: compliance is very important with HIV positive patients. You can't stress that enough. You always want to check for drug interactions because these medications have a lot of them. You want to allow someone specialized to manage antiretroviral therapy. And you want patients with HIV to make sure they're up to date on their vaccinations, and they require more vaccinations than the rest of us. So you want to refer to the CDC guidelines for those recommendations. Children as patients. We're going to skip over a lot of this. I just want you to know that children are not little people. Their kinetics change all the time. So their gastric pH doesn't reach adult values until age 20. So absorption is going to be affected. They have a higher percentage of water, and their blood-brain barrier is incomplete. They have decreased plasma protein, so your drug binding is not going to be as good. So under 6 months, if you have a patient who has seizures, then you have to watch out for those protein-bound antiepileptics. Total body fat doesn't decrease until adolescence, and lean body mass increases more in males than females. And you can see going here, following, it's the differences in drug metabolism in infants and in children. You have to watch for drugs that might be excreted in breast milk. There are some that are okay, some that don't get in the breast milk, and then there are some, such as methotrexate, that the mother will have to formula feed if she's taking them. Geriatric patients, you might as well consider them a different class like children. There are so many changes going on with aging that it's hard to predict or hard to treat them like a 30, 40-year-old individual. So patients will have mental changes. They're more susceptible to delirium and cognitive side effects. They have musculoskeletal changes where they have decrease in muscle mass. They also have a decrease in kidney function. Regardless of what their serum creatinine says it is, elderly patients have less kidney function, have less renal function than a 30 or 40-year-old individual. So you have to watch out for medications that are renally cleared. A great example of that is I knew a patient who took Cipro. It was an elderly woman. She was late 70s, early 80s. Took Cipro, and with patients with renal dysfunction, Cipro can accumulate, and if it accumulates, it can cause hallucinations. And so, the third or fourth day of taking her Cipro for a common infection, she started seeing snakes and things crawl out of the walls, and the wallpaper peeling off the walls. She was hallucinating because of it. So you have to watch out for these medications because they can cause serious adverse events if we don't watch the clearance of the kidney. They're at a very high risk for adverse drug reactions. And you want to make sure when you get a med history from an older adult, ask them for over-the-counter medications and for vitamins because they do tend to take quite a few of them if they think it'll help with arthritis or anything that they may have going on. So make sure you get a complete drug history. Immunizations. Real quick. Influenza. We know that it's important to get influenza. Now there are inactivated influenzas. That's the injection that everybody's used to getting. There's recombinant and live attenuated flu vaccine. The most common is the inactivated. It can have an injection site reaction, but it's very effective, and people start to be immune within about 2 weeks. The egg allergy is no longer a contraindication for this, which is important to know. It comes trivalent or quadrivalent. Trivalent has 2 strains of flu A and 1 of flu B. Quadrivalent has 2 strains of A and B, and I believe quadrivalent has pretty much taken over where the trivalent was in the market. The high-dose trivalent formula is recommended for patients over 65, and it contains 4 times the amount of antigen, and that's because older adults don't mount as high of an immune response if you give them the regular flu vaccine. All patients 6 months of age or older should receive the flu vaccine. Most insurance plans cover it at no cost to the patient. There are certain patient populations that are considered at risk, and you would want to check on those individually. Pneumococcal 13. This is a new pneumonia vaccine, new compared to the other pneumonia vaccine. It's indicated for all adults over 65 who have not yet received PCV13. This one covers 13 different strains of pneumococcal viruses. Excuse me. So you want to cover anybody over 65, patients 19 to 64, the listed medical condition on their package insert. And you do not need to revaccinate PCV13 within a lifetime. Pneumovax 23 is the older pneumococcal injection or vaccine. A patient needs to get both of these. One is not better than the other. They do cover different serotypes of the virus. So you have to separate these by a year, and then you would give the 13, and then a year later 23, and then you can give another dose of the 23 when a patient turns 65, as long as it's been 5 years since their previous dose. Here are your disease-related indications for patients between 19 and 64. Anybody on this list should get these injections between those ages. Tetanus, diphtheria, and pertussis. You can see other indications there. Very commonly used. Herpes zoster, the only thing I want to say about this one is it's very effective in patients, and patients who get shingles once don't have to be told again to get the vaccine. It hurts like you know what. So Shingrix is the new herpes zoster vaccine on the market. It is so popular right now that pharmacies can't keep it in stock. The drug manufacturer cannot make it fast enough to give it for people to even be able to administer it correctly, because you have to give it two doses between 2 and 6 months in between them, and patients aren't able to get that dose 2 to 6 months later because it's gone so quickly once the pharmacy gets some in. And the reason is because Zostavax, which is the older herpes vaccine, is less effective than Shingrix. It seems that the immunity wears off after 5 to 10 years, and it's not as strong as whereas Shingrix doesn't appear to wear off, and the immunity is much stronger. So everything points to Shingrix being the herpes zoster vaccine to use. Plus, Zostavax is a live vaccine that's frozen, so it's limited in some populations that it can be given in, like immunosuppressed patients. So you can see here, Zostavax, the efficacy in patients aged 50 to 59 was 70%. At all ages, it was 51%, and as the patient got older, the efficacy decreased. But with Shingrix, even patients over 80 years old had over 90% efficacy. So that's about it for immunizations. If you have more information, there's a lot, or want more information, it's on Canvas. And if you need anything else, just let me know.